Good evening, ladies and gentlemen, and welcome to JCN Live 2020. And while I'm at it, a very Merry Christmas to one and all. We are absolutely gutted we're not doing these face-to-face at a venue near you. And I promise you, we'll be back as soon as we possibly can. But in the meantime, thank you so much for joining us for our first session of 3 evenings of outstanding content and education brought to you by the JCN. Our first event is called Treating Hard to Heal Wounds, and our fantastic speakers are Dr. Caroline Dowsett and Jacqui Hughes. Good evening, both of you.
Good evening, Ed.
Good evening.
How are you both? Are you well?
Yes,
Very well, thank you.
Good. Well, Merry Christmas to you both. Ladies and gentlemen, as you can see, both our speakers are doing tonight's event from their homes. So please bear with us if we have any technological problems, and I promise you we'll get them sorted as soon as possible. Before we start, a quick note about our partners for tonight's event, Smith+Nephew. Smith+Nephew have been healing wounds in the UK and around the world since 1856. As most of you know, they're utterly synonymous with wound care and have changed the lives of millions and millions in the UK and around the world. So it's a massive thank you for everything you do, but also for partnering tonight's event. It means a lot, so thank you very much. The event will be available on our Facebook page forever. We'll also put it up on our jcn.co.uk website where you can see the event, but also download all the slides. The link for the certificate of attendance will be made available in the comment bar and on a slide towards the end of tonight's event. As I'm sure both Caroline and Jacqui would agree, the more involved you are, the better it is for all of us. So please ask questions. We'll endeavour to answer as many of them as possible before the end of tonight's event, make comments throughout. So without further ado, it gives me great pleasure to introduce you to tonight's first speaker. Over to you, Caroline. Thank you very much.
Thank you very much, Ed, for your kind introduction. And it's a pleasure to join you for this educational event where we're going to be focusing on treating hard to heal wounds. And I'd like to thank the JCN and our kind sponsor, Smith+Nephew, for the opportunity to participate. Before I start, the usual disclaimer, just to make you aware that the presentation isn't intended to serve as medical advice, and the views that I express are mine and don't necessarily represent the views of Smith+Nephew. So we're here tonight to talk about hard to heal wounds and to consider what more we could do in terms of improving outcomes and care for these patients. So let us start with a definition of a hard to heal wound, which is one that fails to heal with standard therapy in an orderly and timely manner. And this definition applies equally to both acute and chronic wounds and is independent of the wound etiology. And many people use the time frame of 30 days. So a wound that fails to respond to best practice intervention within a 30-day timescale. But I personally think that we really shouldn't sit on these wounds for 30 days. We should know from our assessment and reassessment if we've got a patient who we know is going to have delayed wound healing. So by definition, useful, but I think we need to remember that these patients need early intervention. So early recognition is really, really important. If we look at some of the common terminology that's used in terms of these hard to heal wounds, some people describe them as chronic wounds, other people talk about complex wounds, but I think we have to remember that it's a complex patient with a complex wound. Also described as stalled wounds, non-healing, static wounds, wounds that have abnormal healing, or where we've got delayed healing. So all of these pretty much mean the same thing. They describe wounds that are hard to heal, the subject of our webinar this evening. If we look at the burden of hard to heal wounds, we know that 2.2 million patients will suffer with a wound annually. 48% of these will be chronic wounds, 40% acute wounds, and 12 unspecified, based on information from the Health Improvement Network in this study highlighted here. And the annual cost to the NHS of managing these wounds is in the region of 5.3 billion. And that is comparable to managing obesity, which currently stands around 5 billion. So really this is a very big healthcare problem and often not funded appropriately. If we think about where those costs are, we know that 66% of the total annual NHS cost is incurred in the community setting. So many of these wounds are managed in primary and community care. 48% of acute wounds cost-wise in the community, and 78% for chronic wounds. And of course, what we know is that wounds that are healed are in the region of 2.1 billion, and those that remain unhealed, 3.2. So if we can bridge that gap between those healed and unhealed, then of course we can save money. And this isn't a problem that's going away, and we're not really getting on top of it, because the annual prevalence of all wounds is predicted to grow at 11%. Because people are living longer, and people have multiple comorbidities, so we are going to have this challenge and this burden for some considerable time. So we need really to take some action. Really important to look at this from a humanistic point of view and the impact that a chronic wound has on our patients. And we know that chronic wounds impact negatively on patients' physical, mental, social, and spiritual well-being. The patients that I see in our clinics frequently report pain. That pain often leads to patients not sleeping. And as a result of that, patients get quite depressed, anxious. And some of our patients who are in the community setting being seen by our district nurses actually suffer from social isolation. So they become housebound by the very nature that they've got a chronic wound, because that can lead to impaired mobility, which means they can't get out as they used to. And some patients also have poor nutritional status. If we think about patients who have malodorous wounds, and often chronic wounds can be malodorous, that impacts on the patient's diet and their nutrition. So as part of our assessment, we need to consider factors that affect wound healing. And we need to think about those patient-related factors, some that we've mentioned, but I'm thinking about patient's age. So the older the patient is, the more difficult it can be to heal their wound. And really, we can't reverse the patient's age. We just have to think about how we can optimize the patient's well-being. Thinking about comorbidities, and we know that many patients with chronic wounds have more than one underlying comorbidity. So really it's about managing, for example, the diabetes or any underlying inflammatory conditions that might be causing that delay in wound healing. And then we have to think about wound-related factors. So thinking about the wound etiology, thinking about the size of the wound, the depth of the wound, and where the wound is located. Wound duration, really important, and thinking about the longer the patient has the wound, the more likely they are to develop things like infection, which again is a complication that will delay wound healing. And if we think about patients who've got pressure ulcers, very often they're around the perianal area. So those wounds often get contaminated, and again, that can delay wound healing. And then we have to think about things like clinical competency factors. So thinking about your caseload right now, if you're a community nurse, you're part of a bigger team. And you're here this evening listening to this because you're interested in wound care. But think about the knowledge and skills within your team and how you might improve those so that we manage these hard to heal wounds better for the patient. And then we have to think about resource and treatment factors. So thinking about the availability of resources. And this evening, we're talking about single-use negative pressure wound therapy and PICO. And I guess the question is that a treatment that's available for you to use in your patients? And if it's not, maybe we need to think about how we challenge the status quo to ensure that those resources are available so that we can improve patient care and really get that evidence-based practice to the front. So thinking about our overall management of patients who have hard to heal wounds, it's really about that assessment leading to the correct diagnosis of the wound etiology and treatment of the underlying cause. Because, if you've got a patient who's got a venous leg ulcer, the gold standard of treatment is compression therapy. So you really need to address what's causing the wound in the first instance. Then we need to think about managing the patient's underlying comorbidities and those factors that impact on wound healing. And applying the principles of wound bed preparation. So that's about the cleansing and debridement of the wound, treating infection, managing exudate, so that we get wound progression. And once we've done that, then we think about what products or what treatments or devices are we going to use for our patient. And we know that targeted use of advanced therapies like negative pressure wound therapy can really help to heal these wounds that are hard to heal. And then, of course, we have to remember our ongoing reassessment and evaluation. And I guess really to finish up on this point, I think I would like to highlight the importance of documentation. So you've done all of this, really important that you record it in the patient's clinical records. Because if you don't record your actions, then in a court of law, they haven't taken place. So thinking about advanced wound care therapies such as negative pressure wound therapy and single-use negative pressure wound therapy and how they might help us to manage these hard-to-heal wounds. We know that negative pressure wound therapy has multiple mechanisms of action that can help the speed, strength, and improve the quality of wound healing. Negative pressure wound therapy can lead to fewer dressing changes and faster healing of these chronic wounds. We also know that it can reduce patient discomfort, it increases patients' mobility and improves their quality of life. And if we think about the mechanisms of action and how that works to produce these results, we know that PICO, single-use negative pressure wound therapy, manages up to 300 mL of exudate. It protects the wound from those external contaminations. It can improve wound contraction and reduce edema. That ultimately increases blood flow to the wound, which helps promote angiogenesis and stimulates granulation tissue. So over the years, we've seen advances in technologies for negative pressure wound therapy and single-use negative pressure wound therapy that we're focusing on this evening is so much easier for clinicians to use. So when we first started using negative pressure wound therapy, there were great big devices and clinicians were very challenged in dressing application and problems with pumps. Now we don't have those problems. Much easier for nurses in community care to apply this treatment for patients. And of course, much more acceptable to patients. They have small, discrete devices that mean they continue to live their lives with less interruption. And often you don't know the patients are actually having treatment for their wounds. So I'd like to tell you a little bit about our experience and how we've used single-use negative pressure wound therapy, PICO, to improve clinical and health economic outcomes for patients with hard-to-heal wounds. And this is a study that was published in 2017. It's a multi-center economic evaluation study on 52 patients. And we worked with colleagues in Denmark and Canada to develop and implement a pathway for PICO to kickstart hard-to-heal wounds. And then we went on to evaluate the impact of that pathway on both the clinical outcomes and the health economic outcomes. And this study, we were able to show statistical significance in terms of improvement in the healing trajectory of these stored or hard-to-heal wounds. What we also saw was there was a reduction in the frequency of dressing change and a reduction in the cost. And this study has been the subject of a previous Facebook Live session if you wish to hear more about it. But I think the important point from the study really is that it showed that the earlier we intervene in these hard-to-heal wounds, the better the outcomes for the patients in terms of healing. So if we look at the patients and the duration of their wounds from this study, you can see the patients who had their wounds for less than 3 months, 94% of those went on to heal in the study period. If we look at patients who had their wounds for 3 to 6 months, again, 71%. But as we extended to wounds that had more than 6 month duration and wounds that were there for more than a year, you can see that the healing rates start to tail off. So the key message here is identifying wounds very early on in those first 3 months that are hard to heal and commencing single-use negative pressure wound therapy. And that will give the best opportunity for that wound to heal. And my colleagues in Ireland, Pat McCluskey and the team, took the pathway to see what findings they would get in their population. And here you can see that their results were very similar to ours. They had 84.6% healing for those wounds that were less than 3 months duration. And that went to 71.4% for those wounds that were 3 to 6 months, and then tailing off So that any wounds that were there for longer than a year, 14.3%. So again, you know, we have to ask ourselves, do we want to wait until the patients have that wound for 6 months before we start to do anything about improving their health and their outcomes? And again, in this study, they found that dressing change frequency reduced, and the costs were also, the cost savings are in the region of 25%. So similar results to our study. So I guess what I'd like you to think about is think about the patients on your caseload and how long they've had their wounds. And think about how many of those wounds would you say are hard to heal wounds? How long have they been there? And what treatments have you been using on those patients? And what could you do differently in terms of their management based on the work that I've shared with you here this evening? So now I'd like to hand over to Jacqui, who will take you through the project that she's been involved in managing hard to heal wounds with PICO and the very positive outcomes that she's had with her patients. But I'll be back again to take questions and for the discussion at the end of the session. So thank you very much, and over to you, Jacqui.
Thank you, Caroline, for sharing that with us. For my part of the session, I'm going to be sharing some new data with you and 2 case studies on patients with non-healing wounds. In 2019, Smith+Nephew started to carry out a service evaluation across the UK, Ireland and the Nordic countries, hoping to build on Caroline's previous work on hard to heal wounds that you've just heard all about. A service evaluation uses the direction that the choice of treatment is that of the care professional and the patient according to the guidance, professional standards and patient preference. So at all times, the clinician takes the lead on this treatment. We have some early results that we'd like to share with you tonight on 163 non-healing wounds that were collected as part of that data set. You can see on the slide that 86% of wounds were above 6 weeks in duration, and that the majority of wounds were classed as static or had delayed healing. This analysis is really important so it can determine that the right type of wounds were included in the evaluation. These early results have been used to assess rates of healing, frequency of dressing changes, and the impact this method might have on the wider economy and patient outcomes. Each patient was selected using the criteria in Caroline's original hard to heal pathway. And across the 163 wounds, measurements were captured for 12 weeks, irrespective of the wound response to PICO. Wounds were considered to be healed if they reached a wound surface area of 0 centimetres squared. And we'll continue to collect that data throughout 2021 to help build an even better picture of how PICO can improve outcomes for those hard to heal wounds in our patients. The time and cost estimates on this slide were applied assuming that without any intervention, none of the wounds would heal within a 12-week of standard care. So this meant that those wounds would need the same weekly resources that they needed before the introduction of PICO. So what do the actual results look like? Well, you can see on the slide, there was some considerable cost savings made across the 163 wounds. So an approximate cost saving of £59,760 versus standard care was seen across the 163 wounds. And in terms of nursing resource, there was also an approximate reduction of 2,032 nursing hours versus standard care. And when your time is more valuable than ever, particularly with the current challenges with COVID and that ever-increasing workload that Caroline mentioned earlier, the more we can do to help reduce nursing hours, the better. In terms of healing rate, all the wounds displayed some form of healing. So 88 of those wounds went on to being fully healed, with 66 wounds having an overall reduction in size. And this is an amazing result, particularly when you consider the age of the wounds and the level of their chronicity. As you can see, over a quarter of wounds were 12 months or older in duration. So it's a really impressive result that we're seeing. Dressing change frequency was improved. So before PICO, when conventional dressings were being used, they were being changed on average 4.62 times a week. Dressings were changed on average twice a week once PICO was applied. So automatically, you got a reduction in nurse hours. But then more importantly, when PICO was removed and the patient returned to those conventional dressings, you can see that the post-dressing changes do not return to the pre-levels. And, this is extremely positive, as I've just said, as this demonstrates the potential that PICO has in kickstarting those non-healing wounds back onto a good healing trajectory after the therapy's been discontinued. And it's worth remembering that the majority of these patients just had 2 weeks of PICO intervention to deliver these clinical outcomes. I would now like to take you through 2 case studies, both using PICO 14, which uses an enhanced pump that lasts for 14 days. Both studies are on wounds with a minimal depth. However, you remember that PICO 14 can be used on wounds up to 4 centimeters in depth. This case study is a 64-year-old gentleman who had fallen and sustained a traumatic wound to his right leg. He was type 1 diabetic. The medical team at that stage on first assessment decided to go down the route of a split thickness skin graft, which unfortunately went on to fail post-surgery. The nursing team had used a variety of treatments, including antimicrobials, with very little success. And it was at this stage that the clinician decided to start treating the patient with PICO 14. You can see at the first assessment that there was approximately 15% light slough, and the measurements were 7.5 centimeters in length, 4.5 centimeters width, and 1 centimeter deep. There were real concerns at this stage around the patient. They were incredibly anxious and really worried that the wound wasn't going on to heal. Once applied, the PICO dressing was changed twice a week, and application was easy and uneventful. And previous to this, the wound was being redressed 4 times a week. So just by applying a PICO 14 at this stage, immediately reduced the number of district nurse visits. These 2 images show the response of the wound at 14 and 28 days after PICO was first commenced, at which point the wound had minimal slough and had a total wound reduction of 21%. The clinician decided at this stage to continue using PICO for another 2 weeks, not only because of the success of the previous 14 days of treatment, but also due to the history of the wound and the challenges around healing. At the 28-day stage, there was evidence of epithelialization, and the wound measured 6.5 centimeters in length and 3.5 centimeters width. PICO 14 was discontinued and conventional dressings were applied. This wound went on to full healing 2 weeks later. And I'm sure that you will agree with me that this is an excellent result considering the patient's history and the wound challenges. So just in summary then, this case study really described a wound that was complex. With the patient comorbidities and wound care history, the wound was classed as non-healing. A variety of dressings had been used with little success. The use of PICO 14 really helped to kickstart the healing process, which not only resulted in a fantastic clinical outcome, but also helped resource issues by decreasing the number of community nurse visits that were needed to change the dressings. This next case study is a 54-year-old gentleman who developed a dehisced wound following excision of a basal cell carcinoma. The wound was 8 weeks old and was situated on the right scapula. This patient was fit and well and had no relevant previous medical history. The excision dehisced due to a wound infection. This patient was being seen in clinic every day and was being treated with antimicrobials and systemic antibiotics. The clinician used PICO 14 as this would allow for less intervention by the clinical staff, but also give the patient as much freedom as possible. You can see in the images that the wound measured 9.5 centimeters in length, 5.5 centimeters width, and 1 centimeter deep. You can see in the right photo, PICO 14 in situ, and this is just a reminder of how easy PICO is to use. You simply apply the dressing, attach to the pump, and then press the orange button. So gone are the days of big, cumbersome, negative pressure machines, which I'm sure everybody knows and remembers. More patients than ever have access to negative pressure as a treatment for those wounds which are not healing. These images are after 14 days and then 28 days of PICO use. After 14 days, the wound saw both a reduction in wound size with clinical signs of granulation and epithelialization. The clinician at this point decided to use another 14 days of PICO. At the 28-day point, the wound surface reduction was 75%, at which point a conventional dressing was applied. 2 weeks later, the wound had healed fully. Again, this is an amazing result over a period of a few weeks. So just to conclude this case study, this highlights the use of PICO 14 and the impact it can have on both the patient, the nursing workload, and the local health economy. This patient was being seen daily prior to PICO intervention, which was having an impact financially on both himself and his family. Once PICO was commenced, the patient was able to get his life back and return to full-time employment with just 2 dressing changes a week. Getting a seal with PICO was not challenging, and this was despite the difficult location of the wound. In summary, hard-to-heal wounds form a large part of a community nurse's workload. As Caroline mentioned before, if you think of your patients today that you have on your caseload, there will be a proportion who have non-healing wounds. These wounds are more complex than ever, and non-healing wounds continue to be a challenge and are likely to grow in the future. The importance of using evidence-based intervention is crucial in helping to reduce the time it can take to the wound to heal. Identifying those patients who have non-healing wounds early can have a positive impact on the patient and the wider health economy. This has been identified in Caroline's previous work and the data that continues to be collected. The earlier we treat non-healing wounds, the better. The more that these wounds have increasing levels of chronicity, the more difficult they can be to treat. Thank you for your time tonight. I hope you enjoyed the session. Back to Ed now for the question and answer session.
Thank you so much, Jacqui. Thank you so much, Caroline. If it's okay with you, I'm going to crack on with the questions because we've got loads. And we're quite keen to get through as many as possible. So question 1, Jacqui, we'll start with you. How much exudate can the PICO products manage?
Thanks, Ed. Yes, so the PICO products, they can manage 300 mils of exudate per kit. There are 2 dressings in a kit, so basically 150 mils per dressing. We do have more information coming out in the new year around capacity of all the dressings, but we do have different sizes of dressings. And as a clinician, you will definitely notice that some of the larger dressings can actually hold more exudate than 150 mils. But at this moment, we say 150 mils per dressing, 2 dressings in a kit, so 300 mils, which is roughly the equivalent of a standard canister that would be on a larger negative pressure machine.
Fantastic, thank you.
Thank you.
Question 2, Caroline, this is for you. Can you use negative pressure wound therapy on infected wounds?
Yes. That's a really good question, and yes, you can, but of course you need to look at the bigger picture. So I think when we're managing patients who've got infection, we need to optimize the host response. So get your patients, treat their underlying condition, and get your patients well nourished, for example, so they can fight off that infection. Then we need to think about what type of infection am I managing here? Is it a local infection or systemic infection? Obviously, if patients have got systemic infection, you will need to treat them with antibiotics. But for local wound infection, we quite usually use Acticoat dressings, and you can use PICO dressing over the Acticoat. So treat the whole patient, treat the infection, be it local or systemic, and then you can continue to use negative pressure wound therapy.
Brilliant, thank you. Question 3 from Mary. Thank you, Mary. Caroline, for you, is it advisable to use PICO and compression bandaging at the same time, considering that the arterial circulation is okay?
Okay. Very good question. And of course, looking after leg ulcer patients is the passion of my life, really. So I see these patients a lot, and we have successfully used PICO with compression bandaging. It lends itself very nicely to do so. It's very easy to put the compression bandaging over the PICO and bring the tubing up at the top of the bandage and then just secure the little device. Patients wearing trousers, you wouldn't actually know that they had the PICO in situ. So yes, it can stay in place for 7 days with compression on top. And of course, really, it's ill-advisable to stop compression if you've got a venous leg ulcer. So it's really good that you can use both together.
Brilliant, thank you. So question 4, Jacqui, we'll put this one to you. Can you use PICO on deep wounds? If so, how deep?
Okay, thanks, Ed. I think for in terms of deeper wounds, then yes, certainly we can use PICO for wounds that are greater than 2 centimetres. I think the crucial thing to remember is once you go beyond the 2 centimetres is to think about using a filler, such as foam or negative pressure gauze, just to be able to get the negative pressure to all parts of the wound. There is some recent work that's been undertaken by Teresa Hurd and her Canadian team, and 409 of the wounds of the total population, which were 1,326, were actually greater than 2 centimetres and actually went down to 4 centimetres. And if anybody listening today would like a copy of that, if they just want to put that in the feedback, we'd be more than happy to share that with them as soon as we get that data through.
Brilliant, thank you. So question number 5, Caroline, is negative pressure wound therapy more suitable for some types of wounds and unsuitable for others?
Okay. Well, you know, we've used it in all types of wounds, and some of those were in our study, but we continue to use it successfully on many wounds. There was some literature published back in the journal Tissue Viability looking at different wound types. And of course, for chronic wounds, you can use it on pressure ulcers, leg ulcers, DFUs, dehisced abdominal wounds. Where do we have the greatest success? You know, I think a lot of the patients I see are in the leg ulcer clinic, so the success I see is in those patients with compression therapy. But PICO 14, we did some evaluations earlier in the year, and we used it on quite a few dehisced surgical wounds. And linking in with what Jacqui has said, we were able to use it on quite deep wounds, and that really surprised me. We had quite a number of successful usages on patients who had wounds up to 4 centimetres deep. So I think you can really use it on any of these types of wounds. And the other sort of usage for PICO is on surgical wounds to prevent dehiscence. So there's been a meta-analysis with lots of research to show that if you've got patients who are at high risk of developing a wound complication when they have surgery, then using PICO single negative wound therapy can prevent wound breakdown. So for chronic wounds, to prevent surgical wounds opening, I would say any type of wound, really.
Thank you. So the next question, which I suppose is the $1 million question, and a massive room 101 for me in wound care, because I'd love to see negative pressure used more in the community. So from Jane, question for Caroline. SNPWT is not used that often. Why is it?
Okay. Good question. And I think it, you know, I learned this from a colleague, it depends. There's an answer, it depends. And I guess it does depend. And it depends on the area you work in, really. And it depends on who's driving these, the usage. So it could depend on formulary. So many of us here in the UK are confined by the formularies, the dressings we have available to us. So that could be a reason. I think another barrier to using negative pressure wound therapy is that it's perceived to be complex. And if you were involved in the early treatment of patients, which I've been a nurse for 40 years this year, you know, negative pressure wound therapy was quite scary for some of our community nurses. They would ring me before the patient actually came home from hospital with anticipation that they were going to have problems. So I think that sort of feeling might still be there. And what we need to do is to show people how much more straightforward it is, how this PICO single-use negative pressure wound therapy is just so easy to use. You know, I say to the nurses, they say, we haven't used it for a while. I say, YouTube video. You've only got to look at a YouTube video and you can get on and use it. It's not complicated at all. And some patients can even do it themselves. And, we've had a real drive to patients having self-care and supported self-care, particularly around patient safety concerns with the COVID-19 pandemic. So the fact that you can teach patients to use it themselves just shows, that it is something that is easy to use. So I think if you're not using it, then it's very unfortunate. I think it might be worth getting some support from your local tissue viability nurse and Smith+Nephew to maybe revisit it and see where are we now with negative pressure wound therapy, and what can they do to support you getting that back into practice and available to patients. Because we talk about evidence-based practice, and if we're not doing the evidence-based practice, then there's consequences for patients, but there are consequences for us as healthcare professionals as well.
Here. So Caroline, one more question for you. This is coming from Rachel. Can negative pressure wound therapy be effective with palliative care patients?
Okay. Absolutely. I think you've got to think about palliative care patients and think about, is the wound a palliative wound? So if a patient's got, for example, a leg ulcer, they've got the palliative patient, then of course you can use single-use negative pressure wound therapy. If, on the other hand, you've got a patient who's got a fungating breast lesion and they're having palliative care as a result of that, then it would be contraindicated in those patients. So I think it depends on the palliative, whether it's a palliative wound, whether it's a palliative patient. So we have patients who are palliative who have wounds, who of course we want to improve their quality of life. It might be that we want to manage the exudate because it's meaning their life, the quality of life, the last days and hours of their lives are not good, then I would certainly recommend it. But if you've got somebody who's got a fungating lesion, we wouldn't recommend using it on that patient. So I guess it's all about, checking in with the indications of the contraindications. But of course, palliative patients should end their lives with respect and dignity. And if using this helps them to do that, then I would of course say yes.
Brilliant, thank you. So next question for you, Jacqui. This is from Karen. So thank you, Karen. The surgeons in my region apply negative pressure wound therapy straight after surgery, particularly a cesarean wound. When should we be removing it and changing it to a standard dressing?
Okay, thanks, Ed. I think the rule of thumb is obviously the surgeon is applying the PICO to prevent dehiscence. So until they are discharged into your care as community nurses, they will more than likely still be under the surgeon at that stage. We know that PICO can remain in situ for a week. So if you've got an incision that can be undisturbed for that time, then that's fantastic. Be very much directed by your local hospital and your local area, but basically you're looking for the incision to look healthy, to have those markers around healing before you would discontinue PICO. But for most incision patients, you're probably looking at between 1 to 2 weeks of PICO for an incision before it's actually taken off and put back onto conventional dressings.
Brilliant, thank you. Caroline, next question for you from Emma. Good evening, Emma. How can you challenge the cost impact per dressing within the local area? It can be hard to obtain dressings like this when the costs are seen.
Yeah, that's a really good question, Emma. And I think we've all faced difficulties with securing what we call advanced wound care products for patients. And I know when we first started using negative pressure wound therapy in the community, we had to do a business case for each individual patient. And that's when we're talking about those large machines. Of course, PICO is now available on prescription for patients, and many of us are independent prescribers, if not community prescribers. And I think what we have to do is to move away from unit costs to looking at the cost effectiveness of the products. So I hope I've illustrated that in my study. And if you think about the 52 patients in that study, so I would say get a copy of that paper and the subsequent papers that have been published to help you make your argument. Because, anyone in a finance department or the controllers of budgets can't argue with savings of 50,000, savings of 33,000 on small groups of patient population sample size. So I think it's about, if I use traditional dressings that maybe cost £3 a dressing, and my patient takes 6 months to heal, or if I use PICO and my patient heals in 6 weeks, where are what am I spending in the long run? So what am I spending per episode of patient care? So I think move away from the unit cost to thinking about how quickly you can heal those patients. And, the evidence we've presented this evening and the papers that have been published, they show unequivocally that patients heal much quicker with this treatment. So I think that's really the argument for me, and the figures stack up. So take the figures to your commissioners, take the figures to your finance people.
Brilliant, thank you. So we've got our last question after an incredible event. So this is from Lever, and probably for both of you actually, but I'll start with you, Jacqui, and then go to Caroline. Do you have any data on patient concordance using PICO 14?
So at the moment, the data that we have is obviously around our case studies, which I've just shared with you on the screen for PICO 14. We're very much at the start of our journey, but what we find is that with PICO, it's a comfortable dressing to wear, and we've got lots of data around patient satisfaction around PICO 7. So because the dressing hasn't changed, we know that patients tend to be concordant with a comfortable dressing, one that's atraumatic on removal, everything that you would want a dressing to be. So we don't have a lot of feedback around patients not being concordant with therapy. Of course, you need to make that judgment at the beginning as part of your wound assessment. Is the patient going to be concordant with whatever therapy you're going to prescribe for them? But yeah.
Brilliant, thank you.
Over to Caroline.
Yeah, I guess, there isn't anything published specifically around concordance and the use of single-use negative pressure wound therapy that I'm aware of. I think it is work ongoing, as Jacqui says, but in our study of those 52 patients, we had patient feedback. So how comfortable was it? And the feedback was very, very positive in the patient group. So we always ask for patient feedback, but I think compliance and concordance are, they're difficult subjects. And I think sometimes there are many reasons why patients are not concordant with treatment, which is a subject of a whole other webinar, really. But I think my experience, and particularly the PICO 14, we did some case studies of the patients. We've actually got video recordings of the patient. The two patients that stand out for me were just so excited to have the treatment. One went from having a large device stepping down to PICO 14, and she was absolutely ecstatic. And the other patient was healed within a few weeks. So the feedback's pretty good, really. And I think if patients are non-concordant, sometimes it's for other reasons, and sometimes it's because as health professionals we haven't engaged and in good dialogue with the patient.
Brilliant, thank you. Guys, thank you so much, both of you. I thought the event was absolutely awesome, and I hope you get a chance to look back, because the comments we're getting from our delegates have been very kind, and so thank you to you guys for being involved. The certificate for attendance is available now, so please download it. There's also some really cool stuff from Smith+Nephew with regards to PICO and hard to heal wounds. So if you look at Ask About PICO at smith-nephew.com, or if you visit their website, which is smith-nephew.com/PICO, there's a lot more information there. So that concludes tonight's event. Caroline, Jacqui, thank you so much. Have a fantastic evening. To our friends at Smith+Nephew, thank you so much for your support. Genuinely, there's so much work that goes into these events, so a big thank you from me and the team. And to you incredible healthcare professionals, thank you for giving us your precious time. I hope you can join us at 8 o'clock for our next event. I've been told to ask you, you have to log out or finish this event, go onto our Facebook page, and the 8 o'clock event will be available there. So good evening. Thank you very much for your time, and a very Merry Christmas. Good night.
Thank you very much.
Good night.
Thank you.